Well, hello and welcome to another edition of Health Solutions with Shawn and Janet Needham, where Team Needham discusses everything healthcare. I am your host, along with my beautiful wife, Janet, again today. So happy to have her back, and our producer, Lindsay. And we are streaming from the Moses Lake Professional Pharmacy Studio today. And today, you don't want to miss this episode. Stay to the very end because we have board-certified plastic surgeon, Dr. Carmen Kavali, on. And today, this starts off the first of a four-part series on plastic surgery. And today, we're actually going to be talking about breast augmentation. So if you or anybody that you know is interested in that procedure, stay tuned for the next half hour and share this with them. Watch live and let them know that Dr. Kavali is an expert in this, and she is going to go over probably all the questions that you could ever have. And speaking of questions, if you do have questions, you can send those questions in and comment on our Facebook, the Moses Lake Professional Pharmacy Facebook page, or the Moses Lake Professional Pharmacy YouTube site. And you can call in and actually talk. So 509-537 0411, and later on our producer will stream that number in case you have questions. So Dr. Kavali, that being said, I'm going to let you introduce yourself and we'll go from there. Dr. Kavali, welcome to our show.
Thank you so much for having me. I am a board certified plastic surgeon in Atlanta, Georgia. I've been in practice for over 18 years now, solo practice the whole time in the suburban area of Atlanta. My practice is head to toe plastic surgery, all aesthetics at this point. I still do some breast reconstruction, but primarily aesthetic surgery at this point. Breast augmentation is a key part of my practice, a big component in mommy makeovers, as you might imagine. So moms who want to get back their bodies after they've had their babies often do combination surgeries that include breast and tummy. So I think we're talking today just about the breast part of this. I'm happy to be here. Thank you.
That is correct. And we will be sharing some pictures today, and we'll be talking about mommy makeovers later when we talk about liposuction, and we'll talk about tummy tucks later on in the month. So stay tuned for that. So let's just act like we know nothing about breast augmentation, and you're talking to a patient like they're interested in the procedure. So let's just go from there, and how would you address that?
Well, these are the emails we get every single day from actual potential patients. You know, what is a breast augmentation? What do I need to do? What do I need to know about it? Let's start at the very basic aspect. Breast augmentation is breast enlargement. It's not reduction. A lot of people think of it as either, but it's actually enlargement of the breast. And it can be done in a couple of different ways. One is using breast implants. The other could be using fat transfer from somewhere else on your body that you don't want it. We can put it in your breast to give a breast augmentation or enlargement. There are very key differences between those, and what most people have in mind when they're asking about breast augmentation is not fat transfer. It's breast augmentation using breast implants. So when we talk about breast implants, there are two major categories of breast implants. There's saline and there's silicone. And there are a lot of subcategories within those, but saline implants are basically saltwater filled. Both saline and silicone implants have silicone shells. I actually have an implant here. So this is awesome. a silicone breast implant. It has a silicone shell, and it is filled with a semi-solid gel silicone. Saline implants are also comprised of this silicone shell, but what's inside is not this gel, it's water, saline. Key differences: if sometime down the road you have a deflation, one of the implants is ruptured, you have a trauma, or the implants are just very old, and there's, you can see if it sits in a certain way, has a little fold there over the years, that becomes a weak spot. And so you can get what's called a fold flaw that becomes a rupture years down the road. With a saline implant, if you have a rupture, you get a flat tire, and it's obvious that you have a rupture. There's no question about it. With a silicone, because it is that semi-solid gel, you can cut a pizza slice out of the implant. You can hold up the slice and you can hold up the rest of the implant. They both just stay there. doesn't drip or run or ooze or go anywhere. So for that reason, if you have a tear in the shell of a silicone implant, you may not know that that has happened. Because of that, the FDA recommends that you have an ultrasound, a high definition ultrasound, or an MRI 5 years after your augmentation surgery to assess the integrity of the silicone implant. So even if you're fine, you should have surveillance done on the implants. And it's important that you don't confuse this particular imaging with any breast cancer screening imaging. It's completely separate. So if you have a high definition ultrasound, it's just to look at the integrity of the implant shell. If you choose an MRI, it's just to look at the integrity of the implant shell. It's not to assess for breast cancer. So you still have to do your breast cancer screenings, your mammograms, your self-breast exams, as you would anyway. So the next thing, once we sort out saline versus silicone, and I realize I've made silicone sound very negative. I didn't mean it that way at all. They're very different in what happens if they become ruptured, but they're also very different in how they feel. And I can actually show that a little better here. So these are two different silicone implants. And I don't know if you can tell here, but if I hold them up, one looks a little more solid than the other, right?
Oh, yeah.
The other has
Definitely.
more wrinkles. This one's much softer. It has more wrinkles when I hold it up. This one holds its shape much better. So this is a highly cohesive gel implant, and this is a less cohesive gel implant. They both are semi-solids. Neither one is a liquid that's going to drip or run or ooze. But if you want a more natural feeling implant, you're going to choose a silicone over a saline. And you can even choose the density of the silicone within the family of implants. I tell thinner women who don't have a lot of coverage to camouflage an implant to maybe choose what I call the Goldilocks implant. It's the one that's right in between the two I just showed you. So it's a little softer. It has less wrinkling. I call it the Goldilocks. The implant manufacturer, Allergan, calls it a soft touch implant. So an Allergan soft touch is the most commonly used implant in my practice. There are other manufacturers, and they're absolutely fine, worthy products. I just tend to use the Allergan products primarily. Smooth shelled implants. This is very important. So when we talk about implants, we have saline versus silicone. We have what's inside of it. And I mentioned that both saline and silicone have this silicone shell, but this is an important aspect. You can see this is a smooth shell. I don't have a textured implant here with me, but there are other implants that have texturing. It's micro texturing, like you can feel it as a rough surface, and you can see it as more of a muted, bumpy surface. The textured implants are very much out of favor in my practice. And the reason is there's a very rare lymphoma called anaplastic large cell lymphoma that can occur. It is rare, but it can occur in the scar capsule that your body makes around any implant. But that ALCL lymphoma has only ever been associated with textured surface implants. So the solution is to not use textured surface implants. Reasons we used to use them. Yeah, we used to use them because they stay where you put them. And this is important if you have someone with a pectus excavatum, a caved in chest, or a pectus carinatum, more of a barrel chest, where the implants are going to go where gravity takes them, but a textured surface can help them stick into the position you want them to stay. The saline, the smooth shells don't have that sticky factor to them, but they also don't carry any risk, as far as we know, of ALCL. So for that reason, textured surface implants have left my practice over the last couple of years. I know some colleagues are still using them with appropriate informed consent, but I just don't see the need to take more risk with an elective procedure. Right. If there's a risk factor I can remove, that's what I'm going to do.
Yeah, that makes total sense. And I don't know what the cosmetic benefit is of texture. Will you explain that?
Sure. Well, the cosmetic benefit is that it stays in position. So if you have someone with a chest wall shape that's going to encourage the implant to slide together or to slide under the arms. Cosmetically, it's nicer to have the breast stay where it should stay. So what we do instead with the smooth walled implants is, extra bolstering with additional suturing, or put an extra material in what I call an internal bra, a collagen sheet to support the implant in its position until it gets well healed. So there are a lot of nuances to breast augmentation, as you might tell from my ongoings here. But to get back to the start, to get back to new consults, we have to decide what implant. First of all, are you appropriate for an implant? Are you a reasonably healthy person with realistic expectations? So once we've gotten past that, we talk about, are you thinking about saline? Are you thinking about silicone? Once we've got that, now we're talking about, how are we going to put them in? If you just need an augmentation and you don't need a breast lift, you have a couple of choices of incision placement. One is in the fold of the breast, and that's the most common. I'll explain why that is in just a minute. The other is through the lower half of the areola. And then the third would be an armpit incision. I strongly dislike the armpit incision. If you notice, the silicone implants are already filled. So the bigger the implant is, the bigger the implant is.
Right.
And you've got to have a larger incision and a larger path to get the implant into position. And when you're coming from the armpit, that can be a pretty wide track, and the implant can slide back up over time. It's just not an attractive look. In addition, the axillary tissue with the hair follicles has a slightly higher infection rate than some of the other incisional approaches. The periareolar incision under the areola carries a slightly higher risk of nipple numbness or difficulty with future breastfeeding. So for all of those reasons, I like to approach from under the breast, right in the fold of the breast. It ends up being a hidden incision. When someone's looking straight on, you don't really see the incisions. You have to lift the breast up to look for it. The incisions are all under the skin, or the sutures are all under the skin. So there's nothing that has to be removed, and there are no drains. So once we picked our incision site, the next thing we have to choose is, where are we putting the implant? It can go over the muscle or it can go under the muscle. And there are lots of different reasons to choose either. Going back to why we used to prefer textured implants in some cases, when we put the implant 100% under the muscle, it's going to stay there. The muscle's going to support it. What that does, though, is it raises the whole breast footprint. So you've got to still be able to center it under the nipple. That's for 100% under the muscle. The traditional under the muscle approach does not put it 100% under the muscle. It puts it about 80% under the muscles. This being the muscle here, and this being the implant sitting under it. The muscle comes like a fan across most of the implant, but the implant still sits in the breast on the bottom. So it can slide down over time. And then the other approach is above the muscle, taking the muscle completely out of the equation. So when you flex, you don't have any fancy party tricks to do with the implants. They just stay right where they are.
Dang it.
So that's the advantage of being totally under the muscle. You don't have that party trick, or 100% above the muscle. It's when it's partially under the muscle that you can create flexion deformities with animation. So above the muscle, you only want to do if you have adequate coverage. If you are super thin with no breast tissue and no pinch thickness on the upper part of the muscle, you're not going to be able to camouflage an implant. It's going to look like an implant stuck under the skin, and you're going to see wrinkling and rippling when you bend over. That, by the way, is an advantage of silicone over saline. That wrinkling and rippling happens far less often with silicone than it does with saline. So there's an advantage there to silicone. In my practice, I would say 99.5% of the augmentations I do are with silicone implants, and probably 95% of them are under the muscle. And these days, about 70% of them are 100% under the muscle, not just partially. And those are for women who don't need a breast lift. These are just straight breast augmentations. So we're just going larger. We're not having to change the nipple position. We're not having to take away extra loose skin. Everything's just there, needing to be made bigger. And the last decision, I tell everyone, we've got 4 decisions to make, saline versus silicone, over or under the muscle, how we're going to get it there, and what size do we need? How big do they need to be? And that goes right back to that first conversation we have. Where are we starting from? Where do we want to get to? What's realistic? Because you can't just come in and say, with a picture of somebody that's not you, and say, I want these breasts. You can't have those breasts unless you were that person before. The chest wall has to be similar. The existing breast tissue has to be similar. The skin quality has to be similar. The chest wall shape has to be very similar. If you have someone with a wide chest and you brought in a picture of somebody with a very narrow chest, there is no way your breasts are going to look the same as that person. So be very cautious, I would say, I do like wish pics. It's very helpful for me to see what somebody has in mind as their goal, but the wish pics have to be realistic. And it's helpful for me during a consult to be able to say, this is realistic or not, and why. I also use 3D imaging in my practice, vector 3D imaging. So we take our normal 2D photos like you see in every before and after picture, but we also do a 3D image using this system. And what it allows me to do is try on implants they're also preloaded in the system. The implant dimensions are all preloaded from all the manufacturers. So I can pick, a saline or a silicone or whatever size shape I want and put it in that 3D image, and it shows that patient in a very realistic way what she can expect for her results. And it really helps. What it has stopped for me is the rice bag TryOns,
Right.
And I also don't have to keep 2,000 implants in my office anymore for all the potential sizes and shapes that someone could choose from to stuff into their bra. That's a very unrealistic way to size an implant because, first of all, it's going to be under tight skin or under a tight muscle when the surgery is done. And so it's going to look nothing like an implant just stuffed into a bra with me standing behind trying to hold it in to hold the shape. So this is a very realistic way to see the size afterwards and the shape. So the other question it often answers for us is somebody comes in and they want just a breast augmentation. I do an exam and I think, I really think you're going to need a breast lift, but I get it. Nobody wants extra scars. And to have a breast lift, you have extra scars beyond what you would have with a breast augmentation. So this imaging software really helps with that. I say, okay, we're not going to do a lift. We're just going to put the implant in and we'll see what it's going to look like. And pretty universally, they then see why I was suggesting a lift, and it helps them come to terms with it. And, it validates what I'm saying to them, and they don't feel like I'm trying to sell them something, that I really do just want to get them the best result. And that's why I brought it up. So those are the 4 things. What type of implant, where are we going to put it? How are we going to put it in? And what size does it need to be? The one thing we didn't touch on yet is the different profiles of implants. Going back to I think these are similar profiles, so this might not be helpful. But what you can see by the profile is these are the same width, the same base width. So they're going to fill the same dimensions on the chest wall. It's the projection. So the implant goes in like this. So what you see from here to here is the projection of the implant from the chest wall. And I tell people, I can't change your width. That is based on your rib cage and the natural anatomic borders of your breast. I can't change that. Well, I can, but then it's bad. If I pick an implant that's way too wide for you, you're going to have a uniboob, or you're going to have a lot of side boob, or both. Neither one is good. And if I pick one that's too narrow for you, you're not going to get any upper pole fullness. It's going to be like a little plum floating around in space for a grapefruit, right? It's just not right. So the width is fixed. based on your anatomy. But what we can change then, this is the analogy I came up with ages ago, because I had a husband who just kept looking puzzled. And then I realized he was in construction. So I said, you know what? We've got a piece of property. We've got a piece of property that we're going to build on. And we can't change. We can't buy the lot next door. This is our piece of property. Right. We're going to either build a ranch, or we're going to build a 2-story home, or we're going to build a townhouse, or we're going to build a skyscraper. Those are all the different projections of implants. And what they're called, it's a low plus, a moderate, a high, a full, an extra full. Those are your ranch up to your skyscraper projection implants. And the light bulb just goes off and everybody gets it. And what that lets us do is, keep within the proper anatomic borders, but still get the cup size that the woman is typically asking for within reason. So yeah.
That's great. That was a lot of information there. Thank you. Obviously you have discussed that just a few times in your practice, just a few.
Yeah.
So I do have a question going back. Yeah, right. I do have a question going back on breast lift. So you talk about sometimes you'll do augmentation and a lift. Is there any time you do just a lift?
Yes, there is. So if a woman comes and says, I don't like my breast shape and I don't mind being a little bit smaller, then we can just do a breast lift. The reason I say they have to not mind being a little bit smaller is because I'm not taking away breast tissue, but I'm repackaging what they have into a smaller envelope. So visually it looks like a higher, tighter, smaller breast. Even though they might technically wear the same bra size, it's visually a smaller breast because it's tighter and perkier. So the only time you need an implant is if they really have no upper pole fullness. You can get a better breast shape with a breast lift, but what you cannot change without an implant or fat is the transition of the chest wall to the upper change. The upper breast does not change except initially and very temporarily when you have swelling. So for maybe 3 months,
right,
you look like you've got some nice fullness, and then it settles. And you've still got a better breast shape. You've got a tighter shape. You've got a nipple that's pointing in the right direction, but you don't have that roundedness on the top. So if that's what a woman wants, we have to talk about that ahead of time and then decide, are we going to use an implant, or are we going to do the lift, let it settle, or are we going to add a little fat? The nice thing about just doing a lift and not adding an implant from the get-go is you're not burning any bridges. You can always come back and add an implant later. So you haven't destroyed any opportunities, and you've let that woman come to terms with the idea that there really wasn't another option. It had to be, fat or an implant that gets added, not just a lift.
So Janet, do you have any questions for Dr. Kavali?
I do. So we mentioned mommy makeovers. So how long should a lady wait prior to having their makeover after having her children?
Sure. That's a great question. And it's a very common one too. I often have women email and say, I just had a baby. I think it's going to be my last. When can I come in? The answer for the tummy is when you're reasonably close to your pre-baby weight. You don't have to be at your baby weight. You can be 15, 20 pounds off. That's okay. But you can't be 50 pounds off. You need to be reasonably close to your pre-baby weight for the tummy work. For the breast, it's 6 months after you're done breastfeeding. So I'll often have women come in for the mommy makeover consult while they're still breastfeeding. We can go over the educational part of it. I don't bother with the 3D imaging at that point because they might be engorged with milk. Everything's going to change when that's done.
Right.
So, but they've got all the education. They understand the pricing. They're prepared, and they know the timing of when they should come back for the actual surgery. So then we'll see them again for a pre-op visit, a confirmatory consult, and the imaging and the sizing about 5 or 6 months after they're done breastfeeding, and the surgery happens at least 6 months after breastfeeding.
So what about recovery? What are the expectations that a lady should have after she's had her surgery?
So for breast augmentation, the recovery is really not that bad. I say that it's relative. The tummy tuck recovery is much worse. So an augmentation above the muscle is a really quick recovery, less than a week. I mean, you're driving within a few days typically. And I tell people the rule for driving for me is I don't tell you when you can drive. You can drive when you're not taking any narcotics for pain and when you feel like you can react appropriately in traffic. So it is your decision, but on average, with above the muscle, it's within a few days. For below the muscle, in either aspect, the 100% total submuscular coverage or the traditional submuscular, it's a little bit longer, more like a solid week. And that's because the muscle's just tight. It feels like a friendly elephant sitting on your chest. It's like a heavy, tight feeling. Some women say it feels like being engorged, but without the burning pain of being engorged. But just a heavy, tight feeling. It's very important that women right after surgery don't go home and protect themselves. I want the reaching for the coffee cup. I want, you're washing your own hair the day after surgery. I want that range of motion to help soften things up a little more quickly. Nothing herky-jerky. You're not back in the gym for upper body for at least 6 weeks if we went under the muscle, but not a bad recovery, especially in this day of Zoom and the vast majority of people still able to work from home. They're not even taking time off work. They're having the surgery on Thursday, maybe taking Friday off, but they're back at work on Zoom come Monday.
Wow.
So the expectation of how long would a implant last for a client? I'm sure it differs, but there's probably some guidelines on that.
There is. And that's a great question because it's not one that I touched on at all. The average lifespan of an implant, whether it's saline or silicone, they're the same, is about 12 to 15 years. But it's not like an oil change or a tire rotation. You do not have to come in on a certain schedule to do anything with your implants, except 5 years after silicone, you should have surveillance, MRI, or ultrasound to assess the integrity of the implant. But as far as removing, exchanging, there's no schedule for that. It's only when it's time for you, when there's a problem, when you want a size change. And by the way, the number one reason for reoperation after a breast augmentation is a desire for size change. Number one reason. Number two reason used to be capsular contracture, which is hardening of your body's scar. Your body makes a scar capsule around the implant. It's supposed to be there. It's another Goldilocks scenario. If the capsule is just right, then it provides some support for the implant position and a soft breast that feels and looks like a soft breast and not like an implant. If it's too soft, it doesn't give any support to the implant, and you could, over time, with muscle movement and gravity, have a malposition, meaning the implant sits too low, usually too low and too lateral towards the armpit. Or it can be too tight. That's called a capsular contracture, a thickened, hard scar capsule around the implant. And that can turn the implant from a breast shape to a ball shape. And that's some of those women you see look like they have a ball on their chest. They probably have a contracture that they're not having addressed for whatever reason. So a severe contracture would be a reason for a reaugmentation. Implant malposition would be a reason. Deflation we touched on would be a reason. Desire for size change, or breast changes after weight change. So you had your implants, now you've had babies, or maybe you've had weight gain and now weight loss, and your breasts aren't what they were before you had implants. So something needs to be done to match them up again. But on average, 12 to 15 years is what I tell women to expect from their implant.
Cool. So let's talk a little bit about pricing. I know that's probably general, but generally speaking, what are you talking about for breast augmentation enlargement, pricing, and then versus just a lift?
Sure. So for the saline implants cost a little less than the silicones do. That's just our price from the manufacturer. So a saline augmentation is a little bit less than a silicone. I think a saline is around $5,800 to $6,300 all in. That's the OR, the anesthesia, the implant, and the surgeon's fee. We also include your scar treatment, initial scar treatment in the package as well as your surgical bra, And all of your follow-up visits are included. So 58 to 63 for the saline, and a little bit higher, more like 72 to 75 for the silicone. If you add a mastopexy or a breast lift, if you do just a breast lift, you're looking at, I think it's around $7,500. But if you do an implant with a lift, now it's more like $8,500.
And what are you talking? So let's say you must take care of patients all over the nation, I'm assuming. Is that correct, Dr. Kavala?
It is
Dr.
true.
Kavali?
Yeah.
So how do patients get a hold of you, and how do you do the pre-consult? Do they have to come to Atlanta, or how can you do that and make it convenient for the patient?
Well, the nice thing about this day and age, I mean, there are some silver linings. There's a lot less traffic in Atlanta due to COVID. So that's one. But the other is virtual consults. It was something that was not widely accepted pre-COVID, but now it's something people seem to be more willing to do, and understanding that it's a normal thing and that I can get a lot of information and vice versa through just a virtual consult. So for a virtual consult, I'm happy to do that anytime, anywhere. Scheduling, my office number is 404-250-3333. My website is drkavali.com, drkavali.com. Oh, thank you. And I'm on Instagram, and we put a lot of before and after photos on Instagram, and it's at Dr. Kavali, at drkavali.
Great. So, Janet, as we wrap up this session, do you have any final questions for Dr. Kavali?
Well, the only other question I would think a client or a lady might have is just a little bit about qualifications. What are the pitfalls, or what direction should we point clients as far as who should perform these surgeries for them?
Great question. I appreciate you asking this, because again, it's something I didn't get a chance to touch on. The American Board of Plastic Surgery is the only ABMS accredited board that certifies plastic surgeons. When you're searching, it's very important that you look for a plastic surgeon, and that is juxtaposed against a cosmetic surgeon. The reason for that is only a plastic surgeon has had full training, including residency and fellowship training in plastic surgery, including reconstructive anesthetic surgery. A cosmetic surgeon could be somebody who wasn't even a surgeon to start with. Say your internal medicine doctor who takes a weekend course and then decides to call him or herself a cosmetic surgeon. There is no accredited board for cosmetic surgery. There are no hospital privileges for cosmetic surgeons in the vast majority of cases, because it's understood that training is not up to the standards of the American Board of Plastic Surgery. So please don't shortchange yourself when it comes to your body, your health, your future. You want a board certified plastic surgeon.
Thanks for clearing that up, because Janet and I are in healthcare as an industry, and we had no clue about that. So I'm sure there's a lot of our listeners and viewers that really appreciate you elaborating on that, because I had no idea. So thanks for clearing that up, Dr. Kavali.
Absolutely. There's so much misinformation out there. So I appreciate the opportunity to be here. Thank you.
Yep. So last question, and you already told us how to get a hold of you. So that saves me one question. But the last question is, so it's obvious that you have a passion for what you do, but tell us what drives you, what gives you passion about what you do?
Oh my gosh. It kind of goes back to, I think, what got me into plastic surgery. I didn't know I wanted to be a plastic surgeon. This was not what I had planned at all. I knew I wanted to do surgery, but it wasn't until I was already a general surgery resident and I stayed behind after my team had done a mastectomy for breast cancer. We removed breasts for breast cancer. And for this particular woman in inner city Chicago in the 90s, nobody was doing immediate breast reconstruction. But in this particular case, there was a plastic surgeon coming in to do a reconstruction. And I begged my team to let me skip whatever I had next to see what this guy was going to do. And he did a tram flap, where you take an abdomen and you build a breast. And it was like the angels sang, I'm like, oh my gosh, this is what I want to do. This is my calling. And so I went to my program director, and long story short, I am where I am. but I landed in Atlanta and I didn't train in Atlanta. And you don't break into those referral patterns for breast reconstruction unless you've got those connections locally. And I had no idea, so naive, no idea. But what it meant was my practice grew in another direction, and I get to give women back themselves. And it may not be through breast reconstruction. It might be through a mommy makeover. It might be through a facelift. It might be through some liposuction to get rid of that one stubborn problem area that just will not go away. I get to make women feel better about themselves. Men too, but mostly women.
Yeah, that's awesome. And, I'm sure you have a lot of gratified clients. That must be very rewarding. So we will have you back on in 2 weeks talking about mommy makeovers. We're going to be talking about tummy tucks specifically, and then we'll cap our 4-part plastic surgery at the end of the month we'll finish up with liposuction and just mommy makeovers in general. So I appreciate you being on today. That's a wealth of information you gave us. So I really, really appreciate you being on. Thank you so much.
Thank you. So fun. Very nice to meet you both.
You're welcome. Yep. So you've been listening to Health Solutions with Shawn and Janet Needham, where Team Needham discusses everything healthcare. And as always, you can catch us every Thursday, usually for our midweek podcast, and every Monday, 12:30 to 1, every Monday. And speaking of Thursday podcast, our midweek podcast, we'll have Ethne Nance, and she will be talking about how hospitals and insurance companies are in collusion to rip patients off. Today, how we talked about how Dr. Kavali was very transparent about pricing, and she knew exactly what the price would cost, and it was all inclusive, surgeon, anesthesia, follow-up, all that. Well, that's not what happens at hospitals, and that's not what insurance companies do, and they are ripping you, the consumer, off. So we want to expose that, and we want to let people know that free market and transparent healthcare is what you as a consumer need to search out. So stay tuned for that Thursday, 8 to 9 a.m. Thursday, and we've had Ethne Nance on before. I'm super excited to have her back on. As always, you can catch us on Facebook and on YouTube, the Moses Lake Professional Pharmacy YouTube site, and most of the podcast forums. So Google Play, iTunes, and so on. Go to those, our YouTube site, and like it, please. Subscribe and comment so you can let us know how we're doing, and if you want more episodes, what other topics you want. So thank you for tuning in today. Health Solutions with Shawn and Janet Needham. Thanks, Dr. Kavali.